I would like to share with you like a part of a history. January 2005 was the first time or blueprint in my career that I started with the first guided case. Afterwards, to be in Leuven University with Professor Daniel van Steenbergen. The name that was called the technique, but those days, it was a tricky name. It was teeth in an hour. Afterwards, it called Nobel Guide. Afterwards, it's called Nobel Clinician. With that name, we made a lot of publicity in our country. And that goes against us. Who is guiding the guided surgery was the major question. After a while that we were working on it, we start to think, is this a surgical technique? Is this a prosthetic technique? Is this a laboratory technique? Is the guy that cleaned the office the one that will perform the surgery because it's too easy? Should we have experience? Should we know it? And we received this case. This case because we were called the teeth in an hour guys. And what were the mistake from Nobel Biocare? Because when you receive this kind of patients, you say, okay, this is not difficult. Maybe today, but in 2005, it wasn't. It wasn't because when you're seeing the X-rays, this is the bone that we knew that we are able to catch. This is something that we don't know how it will be, and this is clearly not allowed to install implants. But the problem is not the radiography, the X-ray, it's not us, it's not the technology, it's the patient. Because the patient was someone, if you want, like the Sopranos, that pick us from the throat against the wall with a little knife and talk to our ear. Don't even think to put an injection on me, or even think to do a sinus lift, because I have done twice. And you are called the teeth in an hour, so you have to be very clear with me, and don't charge too much. Those are the patients that we don't want to receive, but unfortunately, we receive. So, what do we do here? First, guided complex case. We start to think. We put all our demons on our articulator to start to think what we should do. The tricky thing is that for that time, not today, you have to do a double scanning technique. And with a second scan, you should put some appliance that is called the radiographic guide with your proposal of rehabilitation. What is the tricky part? The tricky part is that digitally, you can overlap to things that may crush. And the other tricky part is that you are not allowed to place an order for a surgical stent without supporting for the implants in the digital view. So we need to fill this space with something that was already used by the teeth. So that was the first time that we started to perform immediate extraction and immediate implant placement guided. So, as Dr. Scott Gunn says, this is the triangle of bone. It's something that we were able to recognize only using a cone beam technology or a tomography. But why should we use a cone beam and not a medical tomography? Because it's less expensive, less irradiation to our patient, and quicker, and with the same results. So there's no need to go for a medical device. Then we play with our models in the articulator. We have a proposal that we cannot try in on our patients because our patient is already with teeth. So we have to be very sure about the work in the lab and with the articulators. And our temporary is a metal frame, wrap around acrylic prosthesis, screw retained. We go into the surgical procedure, we go for the anesthesia, we cut the splinted previous solution, and we make a softly and gentle extraction, because we will need this space to install our new implants. So we have to do it very soft, very easy, and very gentle. This is the classical view of the surgical procedure guided, and this is the classical view of a pathologic position of the teeth, because with less insertion, the teeth start to go forward and upward because of the force of occlusion. And then in the computer, you will realize that this is kind of the correct position. Flapless. Bone wants to be covered, always. Always. So why we have to do a flap procedure if we already know what is going on under the mucosa? There is no way to do it. There is no need. So this is the first vision. This is 10 days. And this is 6 months. March 2007. Procera implant bridge full arch, presented in the Nobel Biocare World Conference on May. One of the first full arch cases is able to do this. Why? Because you prepare it digitally. You know that the parallelisms, because between all the implants is the correct parallelisms. You know that the hole for the screw is in the palatal side. You know that the implant position is in the right place. It belongs to one of the position of the specific tooth. So you will have a good answer for the mucosa. January 2014, 8 years follow-up. As we receive him, as he is right now, and all of you may be thinking, what's going on with the chipping? Maybe there is little chipping. In this case, fortunately, no. Fortunately, because it's not what has happened all the times. Chipping is an issue. So, for us, we were very lucky, and this very aggressive patient comes into other side. He's one of our best friends, best referrals, and probably, as he may think that we are kind of magicians or something like that, he started to refer us some kind of really tough cases. Soft and gentle, the extraction. Let me tell you something that probably you will not realize, or you are not realized yet. The forceps, the one that is provided by beautiful companies, is an instrument created 200 years or more ago. So it's not designed for modern dentistry. It's designed for old dentistry. So you have to be very careful when you use it. because you don't want to stress the hard tissues. So you have to be very careful and know exactly the anatomy of the root, because you don't want to stress the bone with the root. That is a projection of the instrument. So when you do an extraction, be soft and gentle. And if it takes to you half an hour, you will love to have half an hour with an extraction and being soft and gentle, and don't fracture the bone. That is quite important today when you're thinking to do immediate placement of implants. March 2010. Again, someone came from the Sopranos. I don't want more dentistry. I don't want more tests. I don't want more endos, because they don't work in my mouth. You fix the problem to a friend of mine, you should fix my problem. Wow. Wow. Today, wow is not an expression. It's a term. Christian Coachman will teach you how to catch this term from your patients. Wow. Digital technology may allow you to have this rehabilitation, to have this solution in our patients. Combine it, cement retain it, screw retain it, zirconia, pretau, wherever you want. Find the solution. Incorporate the face of your patient in your folders, in your clinical folders. We are treating persons, not mouth. So we have to take pictures of the full mouth. We have to send all the information to the lab technician. And all the information is this: the lips, the pink, the white. But we don't have to be away from the science, from the biological part of the things. And here, in all these cases, there is a little tricky biological secure thing that I will show you, which is the tricky part of all of this, and explain at the end. All of this could not be possible if all this rehabilitation is not stable, and will not be stable just because of the way that we made. This is not stable just because it's screw or it's cement, or is this implant or that implant, or is internal or is external, or is zirconia or is titanium. This is stable because of the structure. The cross is splinted, and look at this image. What you see here, this, 2 molars. That's our secure. That is our insurance. That is our insurance company. This is the only thing that will connect your rehabilitation with the brain. The only thing that have periodontal ligament. Afterwards, this structure will create osteoperception 1 year and 6 months later. And we are charging or loading our rehabilitation 6 months later on the placement of the implants. So we're making a big mistake, because our brain will not recognize what we are pretending that is already recognized. So be careful. You just see in Marie's case with implant fracture, maybe the load protocol is only viewing the osseointegration, but you have to be aware about osteoperception. Maybe in the future we will be more aware to read papers of osteoperception instead of ceramics or zirconia or some other things. So, guided soft tissue regeneration, X-rays, Shebang. Wow. Is this a sister, a cousin, a neighborhood, or something? Wow. This is like a parent of Shrek. This is a human being, stable. When you are stable emotionally, your muscles are stable. Look at this. Look at the nose. Look at the chin. Look at here. Look at the soft tissues. Everything is relaxed. This is stable. An emotional stable person is a complete different person. In the CAD-CAM preparing, what we see here, we see the relation between the hard tissues, that means the roots, the bone, and also we were able to see our proposal that came in terms of a digital rehabilitation, that we are able to see the discrepancy between the contour of the pathological arc and our new proposal. Then we are able to plan, very secure, our rehabilitation, go to the extractions, remove the tissues that we don't want, look at this, preserve this, because will be our insurance, not for vertical dimension. It's not for vertical dimension, it's for physiology. Go with our guided splint guide. The correct decisions in terms of implants is quite important. It's up to you, but there is enough information to make good decisions in terms of implants, in terms of anatomy, surface, connection. Use your instruments for amalgam to carry your material to do the grafting procedures. And then 6 months later, when everything is done, you can use again your combine to do a follow-up. A follow-up of what? Not of the rehabilitation, because you already know how it is. You want to see under the water. You want to see the buccal plate. You want to see all the implant environment. What you want to see? The future of the osseointegration. The future of the osseointegration is not the implant. It's not the surface of the implant. It's the relation of the surface of the implant with the surrounding bone. The future of the osseointegration is the bone and the soft tissues. So if you want to fill a little space with a huge amount of metal, you're wrong. You are completely wrong, because the metal is not a biological structure. In 2014, stable soft tissues, stable rehabilitation, stable people. I'm gonna kill you, she's saying to me. How many videos you take to me? As much as I can, because I need you in my files. I need to share you with all the people in the world to learn, to share everything of our experience that sometimes it's against the publications. Send kisses, do things like this because it's function. You need function. Unique. June 2013, welcome DSD. Why welcome DSD? Because DSD is something that will help you a lot to make a relation between the face of your patient that don't want to smile because he's a monster. She is a monster. unfortunately. What is the problem with us? The problem is that we have nice books, like this one from Magnier and Bulls, but the problem is that the information remains in the books, and sometimes we are not able to bring the information into our case. And that, my fellows and friends, is the major importance of the DSD, because you are able to bring all your knowledge and capabilities to perform a new smile based on information. That is the rule and Christian. So, it brings you into another level, the mock-ups. You use test drive. You can use physically, like a mock-up, or digitally, as you saw, as I use it, because sometimes you are not able to perform a mock-up. When you have this, or the teeth that you saw, it's impossible to do a mock-up. So, use test drive as much as you can, please. And then, our techniques is always the same, with a huge difference down. This is DSD drive. It's prepared and produced with the face of our patient. So we know exactly that we will not have countings, inclinations, longer teeth, and things like that. What is going on behind of this? It's a human being. She or he is not care about implants, is not care about grafting procedure, is not care if it's rounded, it's wherever you want. If it's surface, not surface, 3.1, 3.3, 5, don't care. She or he only wants teeth, only wants to be rehabilitated. So today, with the cone beams and the software, we are able to have all a world of information and relate to our rehabilitation, like you are seeing here. Information not only about the bone, information about the irrigation of that bone. How is the bone inside? How is the relation with the bone, with the roots? How will we perform the extraction? We know exactly how is the anatomy of that bone. How will be the implants in relation to the roots? How many graft materials do we will need to solve the case in terms of solution or rehabilitation? So, this girl, before surgery, immediately after surgery, 24 hours, 10 days. Extreme makeover. Wow. Wow. Man, this guy from Chile. Wow. No, my friends, it's all over the world. I know there is a lot of people doing the same. And you can do it. It's up to you. As you are taking your cameras right now to take pictures, bring your cameras into your office. Not only into the speaker's room. Use it. Take pictures to your patient. Before and after. And those before, use it to make analysis, to learn, to understand what is going on in a human being with an awful mouth. And the only way to do that is with pictures, cameras, iPhones, iPads. It's up to you. Digital technology to have the chance to solve complex situations. Digital technology starts with your camera. Your camera is digital technology. Wow effect. Described and will be described by Christian. The wow effect, not in a mock-up. This is not a mock-up. It is a provisional after surgery. It is something that was prepared with all the knowledge that you know to install the implants in the right way, in the right place, to perform the best rehabilitation and to allow the best recuperation of the tissues, the heart and the soft tissue. Is that true? It's true. Look at this. If you remove it, what you see, soft tissue integration, soft tissue anatomy without scalpels, without second soft tissue surgeries, without grafting, without nothing, just biological memory. Don't forget, we are in a biological environment. If an implant is placed in the right place, there is no need to create papilla. The papilla will find a way to fill that space. Look at this. Wow, this picture is from a book. It's not Orlando's picture. It's from books. But the patient is my patient. Orange surface. Have you ever heard about that? Look at this. Look at this. Multi-unit abutment, screw retainer prosthesis? Impossible. Multi-unit is not for beautiful prosthesis. It is. It is. When you're using in the right way, it is. Because you can remove it whenever you can and whenever you want. You can fix the prosthesis. You can realign. You can do wherever. You can change it without stress the soft and the hard tissues. Who's guiding the guided surgery? Is the big question. Is the very big question. Arc distribution, better implant selection, correct 3D implant position, proper distribution of the load, ensure a stable system. An unstable system means fracture of the structure. Think about that. No cantilever, flapless, immediate function, better aesthetics, and time saving. Time is not money. Time is life. When you're a specialist, you will love to have time, not to have more money, to play tennis, to go with the friends, to stay at home, to fooling around, whatever. Time is not money. Time is life. Guided surgery? No, sir. Implants, teeth, mouth, face, persons, soul. We are treating souls. We are the best psychologists and psychiatrists that exist in the world. If we can change smile, we can change soul. That is a big, big issue. So it's guided rehabilitation, not it's guided surgery. We are not doing just surgery. We are not only placing implants. It's much more than that. And we are doing an interdisciplinary approach. As Team Atlanta, we need to create teams. That involves our front desk people, that involves our people in the laboratory. Everybody is involved in our patients. So, my friends, issues. Issues. Most of you are thinking, no this, no that. This guy is here, this guy is that. Let's see our major issues. Issue number 1, tooth extraction. Have you ever read this? Yes. The most overexposed paper in the last 10 years. This one, from our friends Araujo and Linde. Look at the big mistakes of these papers. We need investigation. We all know that we are not veterinarians. We all know that we don't treat dogs. Let's take these things apart. But look at this. We all know that we don't have to fill space with metal. So don't bring big implants in your cases. There is no need to do that. Straumann is moving into a different concept. Little implants, rock solid, because they understand right now that what will preserve osseointegration for the future is the bone surrounding the implant and it is the soft tissue. So for a poor bone, never a big implant. Ceramic chipping. It is an issue. It is true. But the conclusion, shipping is not so big. The problem was satisfactorily solved with polishing of the shipped ceramic area. Shipping is not fracture. Fracture is due to an unstable rehabilitation. Fracture is something bigger. Shipping is something uncomfortable, little. Screw retained. Wow. The Branimar canons. I was raised by Branimar, so I screw everything. I screw my friends, I screw my wife, I screw everything. With nice result. I have good relations with my friends, I have nice kids, and also I have nice patients. So screw is good to me. But what about screwing? There is no statement about that. You can screw or you can cement. There is something in favor of screw and there's something against screw. There is something good with screw. There is something wrong with screw. But for me, it's good. Screw retained single and multi-unit have more technical complication. It's true. It's more complicated to do a screw rehabilitation. Cement reconstruction exhibited more bone loss. It's true. More bone loss is seen with the cement restoration. 4 to 6 or more implants is well documented. So wherever you want, all on 4, all on 6, all on 8, it's up to you. The more implants you place, the more complications for taking impressions. You heard Dr. Garber says, today we can go digitally with the impression, but we will need like an hippopotamus, is that the correct word in English? Or a crocodile, because the machines to do digital impressions are not so handy. And you have to take the 36 degrees of all the implant abutment impression copy to take a good impression, or the software will not allow you to go forward. So, weird, precision. There is a lot of information. Fractures, weird, problems, but all in single units. So, in the major cases, you can go safe with a full arc. Precision fit. However, the less precise fit of the customized zirconia abutment does not seem to affect their ability to maintain the applied torque. So, again, stable rehabilitations. Stable rehabilitations. Irene Seiler, one of the doctors that is making more investigation on these issues. Zirconia ceramic rehabilitation exhibits a similar survival rate to metal ceramic at 3 years of function. So why don't do it? Stable rehabilitation. That is the only reason. Again, oh, it's for me? No. It's always the cell phones. Fit, passive. Me, Alejandro, and some other colleagues, we had had to print this variation of a technique that is already posted on the webpage of Dental XP. I don't have time to explain it complete, but let me tell you, this could be an implant or it could be an abutment. The implant cupping, and then a custom tray that goes through it to the mucosa. And then you splint it with pattern resin to the tray and the implant. That is more rigid, more stable. Since we are doing this, that we have 5 years, we never cut again an structure. Believe me, never. We shared this with David Garber in Portugal, Cascais. Maybe he's not using it. David, what a mistake. Flapless or immediate placement. Timing of placing the implants. I will not read this. There is no conclusions against one or the other, or in favor of one or the other. There is no problem. There is no need to go with a flap. The effect of flapless surgery on implant survival. The systematic review revealed that the survival rate for unradiographic marginal bone loss of flapless intervention were comparable to the flap surgery approach. So, if you like to go flapless, go flapless. There's no problem. This is the major issue, brain connection. The homunculus. The homunculus is our cortical representation of our body. How much connection, synapses, do we have of all our body in our cortical? Look at what happened to us. Wow! Again, the wow effect. Like this. But look at here, how big it is, our mouth. The stomatological system. A lot of connections that were lost when we do our extraction. The ligament, the periodontal ligament, is the only thing that will protect us against bruxism. Remember, the osseointegration has a brother that is osseoperception. Osseointegration will take 8 weeks. Osseoperception will take 16 months. So be very aware of that. And what is the problem? The problem is that we are pushed by the companies. We are pushed by the industry to use this or to use that implant, to do this or to do that, this material or that material. And let me share with you this little voice audio of my professor, P.I. Brannemark.
Phenomena of osseointegration, osseoperception, are really providing a possibility to substitute with a bone-anchored prosthesis to the body of the human being, and controlled by communication with the brain of the patient.
Osseoperception, osseointegration, controlled by communication of the brain of the patient, not our brain, patient's brain. With this word, I would like to say thank you to all of you and leave the podium to the next speaker. Thank you.